So thank you very much. So in this talk I'm going to give an overview of acute kidney injury for a general audience, and also look into some cases that illustrate some key points. So some of you may recognise this. This is the most famous photo of World War II. This is London under the Blitz. St Paul's Cathedral famously survived. And this wartime episode gave birth to possibly the most famous paper in nephrology history, which is BYWATERS and BEAL's description of patients with acute kidney injury due to rhabdomyolysis from crush injuries. These were Blitz victims who were entrapped, as we can see in this photo, under collapsed buildings, although there were also crush injuries sustained by victims entering overcrowded bomb shelters. So this is actually a photographed original version signed in the top right corner there by BYWATERS. So what did they describe? Well, this is really one of the first descriptions of acute kidney injury as an entity, whereby there's an appreciation of parenchymal renal damage, and that there's actually more to this syndrome than pre-renal or hypovolemic factors. So very nice description. Signs of renal damage soon appear and progress even though the crushed limb be amputated. So these patients have undergone surgery. The crushed limb has been removed, yet the renal injury progresses and is sustained. The urine output, initially small, owing perhaps to the severity of the shock, diminishes further. So in spite of attempts to resuscitate these patients, urine volumes were not restored. And then we see this acute kidney injury metabolic syndrome emerging, uremia. We see edema, thirst, incessant vomiting developing. The blood urea and potassium, raised at an early stage, become progressively higher. They also describe a phenomenon that can equally apply to some of the doctors I find looking after these patients. The patient is alternately drowsy and anxiously aware of the severity of the illness. And of course, there's a very nice description of the phenomenon of uremic encephalopathy. I was able to access the BYWATERS archive courtesy of the Wellcome collection, and this is actually a photographic material really demonstrating the detail of data that was captured relating to, at the top, biochemical and other tests, and at the bottom, fluid resuscitation and urine volumes. And in fact, this was early, goal-directed therapy being applied very scientifically in the early 1940s. They also described, of course, the renal injury, and these are post-mortem macroscopic appearances of the kidney. We can see this intense black staining of the medulla due to myoglobin pigmentation. So I'm going to talk a bit in this talk about kidney function. I think acute kidney injury is much better understood as a clinical syndrome when we understand the renal functions that have been lost. So a very brief overview of renal physiology. I'm going to talk about AKI classification and epidemiology, the causes, complications and management of this condition, some developments in this area, and of course some cases. So what about kidney function? What do the kidneys do? Well, the kidneys remove waste products and chemicals most importantly for medical practitioners, drugs, but other waste products, urea we measure. There are more than 200 uremic products that we don't measure. Regulation of salt and water. So this is the extracellular fluid volume and also composition, in particular the osmolarity of the ECF volume. So by modulating the composition and volume of urine, the extracellular fluid composition is also modified. Blood pressure control by maintaining circulatory volume, but also hormonal regulation through the renin-angiotensin system. We have acid-base balance. We tend to consume an acidic diet. The kidney is a player in excreting acid in the distal nephron, but also of reclaiming freely filtered bicarbonate that is filtered by the glomerulus. Some other hormonal functions, including production of EPO for erythropoiesis and maintaining hemoglobin levels and oxygen delivery, hydroxylation of vitamin D, very important for our calcium homeostasis, and finally also a player in gluconeogenesis. So it's helpful, I think, and we will see some of this in we'll see the value of understanding this in the cases further down in the talk. But I think it's helpful to divide kidney function into glomerular and tubular function. The glomerular function is fairly indiscriminate. We have a massive production of filtrate as blood passes through the kidneys and produces a filtrate. This can be up to 180 litres in 24 hours. Now clearly if this constituted our urine volume, we would die of hypovolemia fairly quickly. So there's this massive recovery function undertaken by the renal tubules downstream. And the renal tubules reabsorb vast amounts of salt and water. They closely titrate the ECF volume. So if we're volume contracted, GFR is closed off, but in addition the renin-angiotensin system is activated, which results in reclamation of salt and water in the distal nephron. And also osmolarity is regulated through the action of vasopressin in the cortical collecting duct. The tubules reabsorb large amounts of bicarbonate that have been filtered freely at the glomerulus. The distal tubules secrete protons, and we have this very close titration of electrolytes. So we have a very finely regulated urine volume and composition that therefore maintains our extracellular fluid composition. So this is a fairly indiscriminate glomerular function, which is waste removal, and then tubular function is really reclaiming the things we don't want to lose in the urine and putting some stuff into the urine in a very fine-tuned way that we need to excrete. And this is a schematic of the nephron. We can see arterial blood coming in here, passing through the afferent arteriole into the glomerular capillaries, out into the efferent arteriole. There is the filtrate formation, there is secretion of products into the tubule, and also, perhaps more importantly, this large process of reclamation of electrolytes and other components of the tubular fluid, and finally urinary excretion. So, what does the kidney need to function? Well, like any organ, it needs a blood flow, it needs oxygen delivery to stay healthy and work. But of course the function of the kidney is dependent on blood flow. The kidneys need to filter blood, the glomeruli do need to be perfused at sufficient hydrostatic pressure that they can do their job. So clearly we need a blood flow for two reasons. In addition, we need healthy glomeruli and tubules. The parenchymal substance of the kidney needs to be healthy and functioning. If we have loss of this through infiltrative or inflammatory processes, we will lose kidney function. And finally, the kidneys need to be able to drain into intact ureters downwards into excretion from the bladder and the urethra. So we need an intact, freely draining urinary tract. So what about serum creatinine and renal function? So all of you are very used to looking at blood tests, and when the great majority of blood tests we look at, we will measure serum creatinine. So what does it actually mean when we're looking at this blood test as regards kidney function? Well, serum creatinine is an endogenous filtration marker. It reaches steady state concentration in the serum when clearance equals production. It is produced from skeletal muscle and cleared by the kidney. So either our skeletal muscle mass changes or our kidney function changes, either of these may result in a change to our steady state serum creatinine. The clearance is dependent not only on the volume of filtrate that the creatinine is in, that's produced by the glomeruli, but also the concentration of creatinine in that fluid. So clearly, if we lose, for example, half of our GFR, the serum creatinine will rise, and when it hits double its baseline value, at that point it will offset the 50% reduction in GFR, and clearance will go back into balance. So the creatinine will stop rising, GFR has fallen, but we have a higher baseline serum creatinine. It's important to note that there is a several hour lag before creatinine rises after a renal injury, even when GFR drops to 0. If a patient underwent a bilateral nephrectomy, for example for renal cancer, it will take a while for their creatinine to reach their new steady state. So 2 or 3 hours after that operation, their creatinine might be 120, 130, but we know that their GFR is 0. So for this reason, in acute kidney injury, eGFR estimations from serum creatinine results are not reliable unless the creatinine is in steady state. I'd like to show you this diagram on the left. So this is 2 patients. One is a 20-year-old male who's 90 kilograms, has a large skeletal muscle mass. This is the blue line. We can see under normal conditions his serum creatinine is 100, and this represents a GFR of nearly 140. We also have an elderly female, 50 kilograms, almost half the size in terms of muscle mass. And her kidney function is roughly half the 20-year-old male's. Because of the lack of muscle mass, the serum creatinine is the same under baseline conditions. So these are the 2 things that are influencing baseline creatinine. The other important thing this slide demonstrates is the exponential relationship between GFR and serum creatinine. So this is not a linear relationship, and we can see as the serum creatinine rises from 100 to 150, we lose 50% of our GFR. If we go up to 200, we're hitting almost 75%. So if we want to intervene and restore kidney function, we need to do it early in this process when the creatinine is rising 1.52 times off baseline values. If we move along this chart, if we get to a creatinine of 600, we can see that for a creatinine to go from 600 to say 900, we're actually getting very little change in GFR overall, maybe 5 mils. So the boat has sailed in terms of restoration of kidney function at this point. These are patients who are more prone to severe metabolic complications. But as a general theme, I would say if we're trying to rescue kidney function, we do it early in the process as the creatinine is moving off baseline values to 1.52 times normal, but the risked patients from renal failure complications happens when the GFR is lower. So how is acute kidney injury classified? So there's been substantial work on this over the last few years. This is the KDIGO classification, which was born really by a mating of prior rifle and Aiken classifications. And there is a bit of detail in this slide, but to simplify this, if your creatinine within 7 days moves to 1.5 times the baseline value, you have AKI. That's AKI stage 1, a doubling within 7 days, AKI 2, a tripling, AKI 3. Now, if your creatinine moves by 26.5 micromoles per litre within 48 hours, that also constitutes AKI stage 1, and you automatically become an AKI stage 3 if you have AKI and your serum creatinine rises more than 353.6 or dialysis is commenced. But if you really want to distill this down, 1.5 rise from a recent baseline, stage 1, doubling stage 2, tripling stage 3. There are also urine volume criteria. So urine volume, oliguria is less than 0.5 mils per kilogram per hour. So for an 80 kilogram patient, 40 mils per hour. If you have sustained oliguria on every hour for 6 hours, you have AKI stage 1. When you have 12 or more hours, AKI stage 2, and profound oliguria for more than 24 hours or anuria for more than or 12 hours, AKI stage 3. So that's the urine volume criteria are generally only applicable in high dependency areas where hourly urine volumes are being measured, although they can be operationalized into averages. But in general, I would say if your patient has a 1.5 times rise in serum creatinine from a 7-day baseline or oliguria for 6 hours, they have by definition acute kidney injury. As we've looked at AKI incidence and outcomes, it's become apparent there's a very strong association between rises in serum creatinine acutely and mortality, length of stay, healthcare costs, etc. So we've now got about 10 years worth of papers on this. This was an early paper which was highly influential by Glyn Chertow and his group. And this was a large 20,000 hospital data set and showing increased mortality, length of stay and healthcare costs with sequential rises in creatinine, but starting with quite modest rises in serum creatinine. Moschino et al. Critical Care 2006, a similar number of patients. Again, very strong association between serum creatinine, acute serum creatinine rises and adverse outcomes. Failure or severe acute kidney injury, the authors described as one of the most powerful predictors for mortality in hospitalised patients, actually a stronger predictor than mechanical ventilation. So that's the acute risk. We understand quite a lot about the associated risk in hospitalised patients. What about the risk of chronic kidney disease? Well, again, emerging evidence. This is a meta-analysis performed by Stephen Coca and his group. And we can see here, if we drill down to severe AKI versus no AKI, we have a 28.2 hazard ratio for developing CKD. If we have severe AKI versus no AKI, we have a hazard ratio of 8 for developing end-stage renal disease. And this is with multivariate analysis, all other factors taken into account, comorbidities, etc. And that's one AKI episode. What is the basis for this strong association between AKI and mortality? Well, we think probably these patients are not dying of hyperkalemia or pulmonary edema or acidosis. What is the basis for this strong association? Well, we do understand that the kidney is a vulnerable organ as regards shock or periods when oxygen delivery to tissues does not meet demand, either due to increased metabolic activity or reduced delivery of oxygen. So the kidney itself, if we look at the cortex and medulla, the medulla in particular exists on a hypoxic precipice. So it has low blood flow. Most of the blood is being pooled in the renal cortex and feeding the glomeruli. But due to these very powerful tubular processes, it has very high energy requirements. So why does even mild AKI correlate with mortality? Well, I think there's 4 things to take into account here. A fall in GFR will often be a normal physiological response to a circulatory insult. The creatinine is going up because it has to. Beyond that, I've touched on this inherent vulnerability the kidney has to problems with oxygen delivery into tissues, oxygen delivery mismatch. So AKI may be a marker of illness severity. There's emergent animal scientific data on organ crosstalk. If a renal injury is sustained, this may result in a flushing of harmful inflammatory mediators into other organs, resulting in acute lung injury or other complications which may adversely affect survival. And finally, although we may not see severe metabolic decompensation early in acute kidney injury, we may see problems with volume overload, because very often patients are oliguric and the fluid balance management has been surrendered to the medical team, and fluid management is challenging. What are the causes of AKI? Well, 3/4 of this is acute tubular injury or pre-renal causes, and in many cases these exist in a continuum. So we have our states of hyperperfusion, sepsis, volume depletion, cardiac failure, hepatic failure. We have acute tubular injury due to these processes or sepsis, and then we have direct tubular nephrotoxicity from drugs and other toxins. A significant and probably rising component of this is acute on-chronic kidney disease. We then have specific urological and nephrological conditions, and this constitutes around 20% of severe AKI, are due to specific renal or urological causes, obstruction or inflammatory renal disease, be that glomerulonephritis or interstitial nephritis. So these causes, which are a substantive proportion of severe AKI, require a specific diagnosis and treatment approach. So it's not enough, unfortunately, just to treat everyone with fluids, circulatory optimization and treatment of infection. 20–25% of patients will have treatable urological or renal disease. Comorbidity, as well as the acute insult, is a big factor. This is one of many studies looking at comorbidities and risk of AKI. This was non-cardiac surgery, patients with normal baseline renal function, age, the emergency nature of the surgery were risk factors, but also in terms of background comorbidities, liver disease, high BMI, COPD requiring bronchodilators. So fitness, ability to get oxygen out there into tissues under stressful conditions is an AKI risk. So we have a chronic risk factor in many cases: diabetes, vascular disease, poor fitness, cardiorespiratory disease. We have the acute AKI insult, and this results in AKI. Sometimes it may be a patient with no comorbidities or risk factors who just has a severe acute insult. We must also bear in mind in many hospitalised patients this may be multifactorial. This is a quite famous pictorial representation of Napoleon's march on Moscow. We can see here the pink-brown band is his troops marching towards Moscow, and we can see as they traverse the Russian landscape they are progressively depleted. They are then reversed at Moscow, and further depletion and division of forces, resulting in a very small residue of troops leaving Russia at the end of the campaign. Now you could see the colour here was GFR of a high-risk patient entering hospital, having multiple insults. This is multifactorial AKI. So this sort of progressive attrition on GFR due to hypovolemic insult, drug toxicity from non-steroidals, acute infection, therapy of infection with a nephrotoxic medication, administration of contrast, etc. We, with the London AKI Network, teach around the STOP acronym rather than the traditional pre-renal, renal, post-renal, although that still holds. And this breaks things down to causes in descending importance: sepsis and hyperperfusion. This constitutes between 50 and 75% of AKI. Sepsis obviously has its own acute severe mortality risk, so that's right up at the top. Always think of sepsis and hyperperfusion first when approaching an AKI patient. We then have toxicity from drugs and radiological contrast, renal tract obstruction, and finally parenchymal renal disease, so interstitial nephritis, tubular interstitial nephritis, infiltrative diseases, etc. This is a diagram explaining the mechanisms of AKI or pathological oliguria. We have decreased renal perfusion, intrarenal vasoconstriction. We may have decreased filtration pressure. In some cases we may have a glomerular injury, we may have a tubular injury, we may have interstitial inflammation, tubular interstitial nephritis, or we may have obstruction. So that's the causes of acute kidney injury. What about the clinical consequences, the complications? So I think when complications manifest in any organ dysfunction, this just does not just relate to the decline in organ function, but the demands which are being made on that organ system. So decompensation occurs when there is a mismatch between function and the demands on function. So in respiratory disease, we may have a respiratory failure that only becomes manifest during exercise or during surgery. In renal function, we may have pathological oliguria, but complications only emerge if the patient's administered a lot of intravenous saline. And the metabolic demands of these patients may vary. Some patients need more kidney function than others. And it's this mismatch between supply and demand that results in complications. It's important to note that in critical illness, kidney function may be declining at precisely the point that metabolic demands are rising. And this is why we we may often see complications arising fairly early in AKI and critical illness. What are these complications? So if you take away kidney function from one of my earlier slides, what would happen if we remove those normal functions? Well, metabolic acidosis, hyperkalemia, dysregulation of ECF volume and osmolarity. I mean, characteristically, most often manifest as edema, peripheral or pulmonary edema, high phosphate, low calcium. Calcium is bound by phosphate acutely, but also the effects of diminished hydroxylation of vitamin D come into play after a few days. And then finally, as was so eloquently described by BYWATERS and BEAL, the uremic syndrome. This is due to the accumulation of protein breakdown products. We may see vomiting, encephalopathy, serositis. This may result in pleural or pericardial effusions, which may be hemorrhagic. We may see uremic gastritis, coma, and even death. This is a slide from the NCPOD inquiry looking at deaths with acute kidney injury in the UK. And we can see of patients who died with AKI, acidosis and hyperkalemia were felt to be, were demonstrated through case notes review to be significant causes of death. Hyperkalemia in acute kidney injury will, if it's severe, result in cardiac decompensation. So the problem here is actually achieving electrical excitability within the myocardial cells. To depolarize these cells, need to move potassium from the intracellular compartment into the extracellular compartment. If they have to do this uphill against a high extracellular fluid potassium concentration, this is more difficult. So the problem, we see this manifest early as T-wave tenting, but then we start to see dampening down of the electrical activity. We see broadening of the QRS complexes, bradycardia, and we will even see sinus arrest and asystole. This is a picture showing someone with a potassium of 8 and the response to calcium gluconate administration, which is a temporary measure while extracellular fluid potassium is lowered. What about ECF expansion and volume overload? Well, I think we all have good awareness of pulmonary and peripheral edema and the harm this may cause. But in addition, there's emergent evidence about the risks of cerebral edema in this context, myocardial edema resulting in conduction disturbances, impaired LV function and diastolic dysfunction, hepatic congestion resulting in impaired synthetic function and abnormal LFTs. We may see gut edema leading to malabsorption and ileus. Tissue edema may impair wound healing and lead to prolonged use of surgical drains. We may also see, and this is an emergent concept, renal fluid-induced acute kidney injury. Is that actually a problem? So clearly it can be harmful to congest the kidneys. This may result in hypertension within the renal parenchyma. Obviously the kidney sits within a capsule, so if we have swelling of the kidney due to volume overload, this may impede function. Similarly, venous congestion, renal venous congestion, may also impair kidney function. So I think there's this emerging concept of the harms of volume overload, but specifically how volume overload may impair kidney function or hinder recovery after AKI. So we must be judicious about our fluid therapy. This of course is a X-ray showing pulmonary edema, and this patient has a uremic encephalopathy with a urea of 80. And we can see this very marked uremic flap. This is exactly the same as a hepatic flap. The problem is uremic metabolites impairing proprioceptive function in the brainstem, and this leads to a loss of joint position sense. So these patients can also become ataxic. What about the management of acute kidney injury? Well, there's quite a lot of this in the London AKI network resources, also the Think Kidneys resources. We have a lot of national guidance that's available. Our own in-house resource, we've attempted to synthesise much of this and make it accessible. But what do we do about these patients? Well, I think there's an appreciation that this is often done badly. This was the NCPOD inquiry, which demonstrated in patients who had died with acute kidney injury, failures in risk assessment, prevention, monitoring, recognition, therapy, and escalation to specialist and critical care services, as well as ongoing deficiencies in NCG 50 implementation. That's NICE Clinical Guideline 50 on management of acute emergency admissions. So how do we treat these patients? Well, this is an overview. So we need appropriate systems, for secondary care of acute kidney injury. We need appropriate secondary care systems in place. So this is implementation of the NICE Clinical Guidance number 50. So that's consultant reviews of new admissions, physiological monitoring plans, early warning systems, and where possible, outreach systems to rescue deteriorating patients. We need links and contacts that are accessible with the local renal unit, not only for dialytic therapy, but to get advice on diagnostics and disease-specific treatment, and to transfer some patients for specialist inpatient care. And of course we needed adequate radiology and pathology support. So we need to be able to do ultrasounds and CTs of the kidneys. We need to do blood tests in a timely way. So at patient level, well, we'd obviously start where possible by in the pre-AKI stage. This is often not a very common opportunity. The bulk of secondary care AKIs is community acquired, and any prevention would happen in primary care. But where possible, we'd like to assess patients who are identified as at risk, and those are patients with chronic kidney disease and other comorbidities, such as diabetes and vascular disease or heart failure, and where they know they're about to have a potentially nephrotoxic insult. In such patients, we'd like to, where possible, institute preventive measures, maintaining the circulation with good hydration and resuscitation, where radiological contrast is being used, contrast prophylaxis, and avoidance of nephrotoxins. We need to monitor patients who are at risk to establish whether AKI has emerged, and this requires general observations, but obviously monitoring of the serum creatinine values and urine volumes where possible. If AKI develops, we have a specific passage of care which we would like to institute. If this is successful and the patient starts to recover, we need appropriate aftercare. We need to establish whether their serum creatinine has returned to baseline values. If not, this requires ongoing follow-up. If they don't respond to therapy, then clearly some escalation from the general ward area will be required. So they may require transfer either to the specialist renal unit or the critical care unit. So the basic care bundle, we would recommend this is activated certainly in patients who have had a 1.5 rise in serum creatinine. For smaller diagnostic thresholds, such as a 26.4 rise from a baseline within 48 hours, one can use medical judgment. One might wish to just recheck the serum creatinine level. But certainly for a 1.5 rise, we would say we need to activate a clinical response, and this is a medical emergency. So such patients with significant AKI need a full set of physiological observations. We should do a circulatory assessment. If they're triggering physiologically, they should have oxygen, resuscitation should begin, and where possible, if we have outreach systems in place, they should be contacted. Fluid therapy, so this maps to both NICE and the Gift Us Up UK guidance. So for resuscitation in AKI or any other context, we should be using bolus therapies. We should assess the patient clinically, and bolus therapy and assess response. We would recommend 250 mils of filling using balanced crystalloid, or gelifusin. I think once they're fluid replete, we need to have a maintenance regimen, and if they're oliguric, this may be a reduction in the baseline fluid requirement. So anything sort of for complete oliguria, insensible losses, 500 mils a day orally. Maintenance fluids always need to be tailored. as regards with appropriate monitoring of electrolytes and volume assessment, fluid assessment. Monitoring, well, ABG and lactate in patients who are hyperperfused is appropriate. This is not something we would mandate, but a urinary catheter may be useful to assess urine volumes, to assess a response to treatment, but also get an accurate handle on fluid balance. Daily, sometimes twice daily electrolyte monitoring and serum creatinine monitoring. Blood gas may be appropriate. Venous bicarbonate can be useful. We'd recommend daily weight, fluid charts, minimum of 4 hourly observations for the AKI patient. They may require more, and regular fluid assessments. What about investigation? Well, we would say some investigation is mandatory in all AKI unless there's multi-organ failure, a very obvious precipitant. NICE guidance would suggest a urine dipstick. If this is abnormal, consider parenchymal renal disease. An ultrasound, if there is no obvious cause for AKI, should be performed in less than 24 hours to exclude obstruction. And one can consider more specialist tests such as myeloma screening, autoimmune screening. Liver function, clearly hepatorenal syndrome, an important cause. CK in rhabdomyolysis, very cost-effective blood test. We see rhabdomyolysis missed quite frequently in AKI. And if the platelets are low, we would expect a full blood count to be done. If the platelet count is low, consider microangiopathy and do other hemolysis screening. In terms of more generic supportive care, AKI isn't only caused by sepsis, but puts a patient at risk of sepsis. So we should certainly treat causative sepsis promptly, but be on the alert for AKI patients of other causes becoming infected. We'd recommend stopping potentially nephrotoxic medications, metformin, potassium-sparing diuretics. If there is relative rather than absolute hypertension, but certainly if there's absolute hypertension, one should hold antihypertensive medication. And we'd recommend avoiding radiological contrast where possible, but if it's required, give contrast prophylaxis. So in some situations it will be necessary to investigate patients with radiological contrast, in which case intensive monitoring, prophylactic therapy. Who should be referred? Well, again, this now maps to, this was our original Lakin guidance, this maps to NICE guidance. So any AKI, whether there's a strong suspicion of renal disease, either because of a positive urine dipstick or known comorbidities such as myeloma or autoimmune disease, poisoning. So these are more complex causes that require disease-specific solutions delivered by a specialist. So these patients should be referred immediately once it has been established that they have AKI. We have guidance on the website around how to get in touch with appropriate specialists in London. As regards obstruction, so if there's obstruction diagnosed, this might be relieved by catheterization and bladder outflow obstruction. But many patients will have upper tract obstruction, which requires more specialist urological management, either urological interventions or interventional radiology interventions. So any patients who may have renal or urological disease who have got AKI, we would recommend they are referred to local specialists. Similarly, patients who progress to AKI through stage 3 should be discussed with nephrology services. I would say that's outside of the ITU, patients with multi-organ failure. And clearly, if the cause of AKI has not been established, that's another reason under NICE guidance to get specialist advice. AKI with complications, so we should treat complications as a bridge to imminent recovery or renal support. We've established short-term treatments for hyperkalemia, so insulin and dextrose. Calcium gluconate, if there's an ECG abnormalities. We can give bicarbonate if the patient has space in terms of their extracellular fluid volume. 1.26% isotonic bicarbonate can be very effective in resulting in a sustained rise, a sustained reduction in potassium when we have hyperkalemia due to AKI with acidosis. We can also use salbutamol nebulizers, beware tachycardia. And it's worth bearing in mind the insulin dextrose intervention is a temporary measure until we've reconstituted kidney function or renal support has been commenced. It should not be given repeatedly in patients who have not had restoration of kidney function. Acidosis, well, I've touched on the use of isotonic bicarbonate. Clearly, renal support would be the other mainstay of therapy for AKI acidosis. Fluid overload, so conventional supportive measures, oxygen therapy, CPAP, furosemide in a volume expanded patient with pulmonary edema and AKI, higher doses of furosemide than we might normally give. The dose response curve is moved to the right. And if the patient is hemodynamically stable, intravenous nitrates may also be useful. Uremic AKI, no specific therapy other than renal support or reconstitution of kidney function. I'll say that again. No other specific therapy other than reconstitution of kidney function or renal support, but clearly we should handle patients who have a reduced conscious level in a conventional way. So Glasgow Coma Scale, airway protection, escalation to intubation, etc. So what about fluid therapy in AKI? Well, I think we have separate talks on this on the website, but I think it's agreed that hemodynamic optimization is beneficial in AKI. We should use all clinical data to assess the patient's volume status, history, drug history, clinical assessment, cardiovascular observations, jugular venous pressure, presence of edema, skin turgor, etc. There's been no benefit shown to albumin versus normal saline. And another key message, some concerns regarding HES safety, that's hydroxyethyl starch, may confer an increased risk of AKI and resuscitation of sepsis. The NICE fluid guideline, which parts in 2013, would recommend resuscitation fluids. Crystalloids in general be used, no embargo in gelifusин. With these resuscitation fluids, they generally have a sodium content between 134, which is Hartmann's solution, Ringer's lactate, up to a sodium of 150, which is normal saline. If we are struggling to resuscitate a patient and they've had a substantial amount of crystalloid or colloid, we would recommend senior review. Protocolized hemodynamic management, some variation in the outcomes of studies in which this has been utilised, but this is an approach which has strong support in some quarters. There are no there are no generic therapies for AKI for the acute tubular injury of acute kidney injury due to toxicity, hypoperfusion, sepsis. So there are disease-specific therapies for many renal diseases, and these are well proven, but AKI per se, no specific drug therapies, and this is not no evidence, this is actually evidence of non-benefit. So these agents that are on the slide have actually been formally trialled. So no evidence of benefit for tight glucose control, furosemide, dopamine, phenoldiprem, natriuretic peptide, insulin-like growth factor, or adenosine receptor antagonists. The AKI versus CKD assessment, so this is something many of us struggle with. A patient enters hospital, their serum creatinine is found to be high. Do they have chronic kidney disease or is this acute kidney injury? So I'd preface my remarks by saying that it's always better to assume it's acute because that is the higher risk situation until you've proven otherwise. But clearly we'd be looking at baseline serum creatinine values. If these are not available and the patient has small scarred kidneys, this would suggest chronicity. Some patients with chronic kidney disease have preserved renal mass, but if the kidneys are small and scarred, that is highly suggestive of chronic disease. If the results are moving very rapidly, this suggests acuity. Sometimes we do actually need to do a kidney biopsy to establish how acute and reversible the pathology is. Anemia can be a marker of chronicity, but many patients with AKI due to multisystem diseases or critical illness are anemic for non-renal reasons. The other results, I would say, calcium phosphate levels are unreliable as a differentiator. Clearly, a great deal of research in biomarkers. This is still an evolving field. We are very reliant on serum creatinine values in the clinical world. Serum cystatin C may have value, and in addition, injury biomarkers or functional biomarkers. So the idea of moving towards a renal troponin, where we may see an acute rise in a substrate shortly after a renal insult, and either institute a monitoring plan or indeed instate a therapy to reverse or halt further injury. So I think these have great potential for more precise diagnosis, early intervention, and indeed treatment planning, but still not properly operationalised into common clinical scenarios, and a work in progress, but an exciting area. So I'm going to move into a number of case studies to illustrate some of the points that I've gone over in the talk. So the first case, a 78-year-old male with chronic kidney disease, baseline serum creatinine 130, peripheral vascular disease, diabetes, hypertension, on an ACE inhibitor and a diuretic. So here we see a number of risk factors for AKI. These are chronic comorbidities that confer risk of this condition. We have age, we have CKD, the most important risk factor, vascular disease, diabetes, hypertension. They're on an ACE inhibitor, and diuretic use may be a risk factor if the patient's hypovolemic on presentation. So these are not uncommon conditions to cluster at patient level, and they are all risk factors for AKI. This patient, in terms of their acute insult, they fractured their neck of femur, blood loss, with the use of non-steroidal analgesics. They become breathless due to pneumonia, but as they were post-operative at this point, had a CT pulmonary angiogram with contrast. Their creatinine was 220 on admission, but by day 8 was 800, and at this point had evidence of decompensation with hyperkalemia and severe acidosis. So this patient required dialysis, and their creatinine on discharge was significantly higher than on admission, suggesting that they were likely to have lost kidney function long term as a consequence of the AKI on CKD they suffered. So as learning points, this is multifactorial AKI, many comorbid chronic risk factors, and several acute insults. In terms of how this patient's care might have been optimised, while they could have been risk assessed, they could have been resuscitated more effectively, nephrotoxins may have been avoided. They certainly could have been more closely monitored, such that we detected AKI before the life-threatening complications emerged, and early therapy could have been improved. This is not an uncommon clinical scenario. The next case, a 19-year-old female presents with fever and malaise, blood pressure 85/60, a petechial rash. Baseline serum creatinine is 60. I've actually invented this baseline value. Many young fit patients won't have baseline values, but I'd say a 90-year-old female, a serum creatinine of 90 is unusually high. And they have an elevated serum lactate. So here we can see evidence of severe sepsis, there's circulatory instability, hyperlactatemia, and this patient has developed a stage 1 acute kidney injury with no background comorbidities of note. So we'd say the likely etiology here due to the petechial rash was meningococcal sepsis. This may be present in meningococcal meningitis, but it indeed can purely present with septicemia with no meningeal features. So this is AKI secondary to sepsis and hyperperfusion. If we look at our STOP acronym, number 1 on the list, and in a young fit patient, if they develop AKI in the context of sepsis, this is a marker of illness severity. This is a patient with profound physiological deterioration. So resuscitation, prompt antibiotic therapy, supportive care. Case 3, this is a 56-year-old male. Baseline serum creatinine is available and is 82. He attends his GP surgery with malaise and cough. His creatinine has risen to 550. The GP is called to alert them to this fact, and quite rightly he's referred into the local acute medical team. He could have come straight into the renal unit. We'd have certainly been happy to receive him with that history. When he sees the acute medical team, he does have a urine dipstick, which is blood and protein in large amounts. So this is a patient who would say probably has parenchymal renal disease. They are anuric and their creatinine continues to rise to more than 700. They have a falling hemoglobin to 7.6. The hyperkalemia is treated with multiple doses of insulin and dextrose. Eventually they have an emergency transfer for renal support. And we did a same-day biopsy in this patient, and they were found to have crescentic vasculitis. So this is the chest X-ray. We can see this is there's a dialysis line in situ here. This is a little like pulmonary edema, but is more in the mid zones. So like pulmonary edema, but in the mid zones, without curly B lines, without fluid in the fissures, without, this is obviously an AP film, cardiomegaly. That is very suggestive, that alveolar mid-zone shadowing without other features of cardiac failure, very suggestive of pulmonary hemorrhage. In this case, we have a falling hemoglobin with a likely vasculitic renal disease. So this is pulmonary hemorrhage due to pulmonary vasculitis. This patient was found to be ANCA positive, P-ANCA, and they had a reasonably high MPO titer. They had a raised transfer factor on lung function testing in keeping with pulmonary hemorrhage. They were randomised in a study. They received immunosuppressive therapy with steroids, cyclophosphamide and plasma exchange. Recovered with the baseline serum creatinine substantially higher, although they were off dialysis, than the baseline value. So this is AKI secondary to parenchymal kidney disease, vasculitis. We need immediate referral to nephrology services. I would say patients who present, who appear reasonably well, as this patient did when they walked into their GP surgery, but have had a sudden rise in serum creatinine in the absence of any systemic physiological decompensation. One should always think about renal disease or urological disease. I'd say in this case the repeated use of insulin and dextrose was unnecessary. This was clearly an indication for renal support. And when we do detect renal disease such as acute glomerulonephritis, be mindful that these diseases, vasculitic diseases, systemic lupus erythematosus, etc., these diseases can affect other organ systems. Case 4. So this was a 22-year-old female with a new diagnosis of Hodgkin's lymphoma. They have a progressive decline in conscious level. They're intubated. There's a concern regarding cerebral lymphoma, so they justifiably have emergency CT, MRI and lumbar puncture. These show no abnormality. Urine volumes are maintained, in fact are somewhat high. The creatinine rises to 180 from a baseline of 55 and urea is 38. So we can see a patient with quite a low baseline serum creatinine value. This is AKI 3, this is severe AKI, and we have quite marked, probably due to metabolic activity, we have quite marked uremia. So I felt this was the cause of the patient's coma. We instituted renal replacement therapy to reduce the uremia. The patient woke up. We investigated her for evidence of obstruction. I'd say anyone with cancers, lymphoma, metastatic cancer, lymphoma, pelvic malignancy, retroperitoneal malignancy, always go the extra mile to exclude obstruction. Always think obstruction in cancer and AKI as a first port of call. So this patient actually did have pelvic ileocecal dilatation and ultrasound, and CT scanning showed extrinsic compression on the ureters from lymphadenopathy. They had retrograde stenting from the bladder, treatment for lymphoma, made an excellent recovery and creatinine returned to baseline. This is a renal ultrasound scan showing pelvic ileocecal dilatation. We can see this sits inside the white line, and this expansion of this fluid sac. So this is not cortical cysts. This is between the medulla and the drainage system. So this is PC dilatation. So the learning from this case, so AKI secondary to obstruction, extrinsic compression of the ureter is secondary to lymphoma. Always think obstruction in cancer. In this case, I think there was an underestimation of the AKI severity. A creatinine of 180 in this patient was severe AKI. Good urine volume does not mean no AKI and does not mean no obstruction. So if we think back to the physiology teaching we did at the start of this talk, we have a massive volume of glomerular filtration. If our tubules don't work, we can have a very reduced GFR but still have a maintained or even increased urine volume. So our GFR could go from 180 to 10, but if our tubules aren't reabsorbing salt and water, we will have a poor quality urine of maintained or even increased volumes. And this type of tubular dysfunction we do see in obstruction. Finally, don't miss uremic encephalopathy. I think still does get under-recognised. 35-year-old patient with Crohn's disease, sepsis, small bowel resection, high-dose steroids on TPN and nasogastric feeding. Baseline creatinine was 40, now 170, severe AKI. And we can see here quite profound metabolic decompensation with a very high urea, bicarbonate of 15, and a phosphate of 3.1 in quite a vulnerable patient. So we actually instituted dialysis in this patient, and this relates to the supply. You know, we can institute dialysis or renal support in patients with creatinines of less than 200. In this case, they did have significant AKI, but also a lot of metabolic demands due to nutrition, surgery, steroids, etc. So renal support, we're treating the complications, not the absolute kidney function. Case number 7, 46-year-old with lymphoma has chemotherapy. 2 days post-chemotherapy, LDH rises to 2,000, creatinine bumps to 140 from 90, and becomes profoundly hypophosphatemic and acutely hypocalcemic. So we would recognise this as tumour lysis syndrome. Urate was high, and in this instance we instituted emergency dialysis to reduce phosphate. So these patients, they've had a massive release of lymphoma breakdown products. Phosphate is produced, this overwhelms the system, so we're getting really severe hyperphosphatemia due to production as well as reduction in renal function. So again, the supply-demand concept. In this case, calcium phosphate precipitation can have serious and lifelong effects. We can get calcium phosphate deposition in the kidneys, which can result in irreversible kidney damage. We do tend to avoid IV calcium in tumour lysis syndrome. This binds the phosphate and precipitates it, so the goal of therapy is really to reduce the phosphate level very quickly, so emergency dialysis. So this is AKI secondary parenchymal disease, tumour lysis syndrome. We should anticipate AKI and prevent it. And the need for renal support is not just dependent on the level of renal impairment, but on decompensation. Finally, a 73-year-old male, background of ischemic heart disease, left ventricular failure, CKD. Baseline creatinine is 140. We'd all recognise this patient. They're on an ACE, spironolactone, furosemide and a beta blocker. They're admitted with pneumonia and the creatinine rises to 180. They are profoundly hyperkalemic on admission. This is real life-threatening hyperkalemia, 7.8, with ECG changes, not acidotic. So here we've got a patient with CKD who's lost further kidney function, but as an ACE inhibitor and perhaps more importantly spironolactone on board, and has become profoundly hyperkalemic. This patient had fluids, urine volume monitoring and antibiotics and 4 rounds of insulin and dextrose, but actually died of hyperkalemia. And I would say this patient should have had emergency dialysis. So this is the machinery of distal tubular potassium secretion. This is what we do to get rid of excess potassium. We deliver a GFR, a tubular fluid, to the cortical collecting duct. We then have these potassium channels, the NAK ATPase and the K channel, and they drive potassium into the urine, and this is all aldosterone mediated, and spironolactone will block this off. the ACE inhibitors reducing the production of aldosterone. What little aldosterone is getting to the tubule is being blocked by spironolactone, and in addition we have reduced delivery of tubular fluid. So this perfect storm for life-threatening hyperkalemia. So this was AKI secondary to sepsis, AKI and CKD. Other factors may influence the degree of metabolic decompensation and indeed the timeliness of recovery. Spironolactone, a very long half-life, may take a week to wear off. So drugs are important in assessing risk at patient level, and severe hyperkalemia in the context of spironolactone use, I'd always get specialist advice. Many more teaching materials on London AKI Net, and also look to the Think Kidneys website with our mobile app, which we're just in the process of updating. And thank you very much for your attention.